I'd like to now warmly welcome Dr. Yash Gawarikar as our first keynote speaker this morning. Dr. Gawarikar is a consultant neurologist and senior staff specialist at Calvary Public Hospital and VMO at Calvary Bruce Private Hospital. And he's also the director of the acute stroke service at Calvary. His special interests are in hyperacute stroke and in movement disorders, especially Parkinson's disease, and the use of complex treatments like Duodopa and DBS. Many of you here will know of those treatments for advanced PD and for headache disorders. So today, Dr. Gawarikar is going to speak with us about treatment pathways from diagnosis to advanced therapies. Welcome, Dr. Gawarikar.
Thank you, Marcia, for the introduction, and I'd like to thank Parkinson's HCT for the invitation and for this opportunity. I've got a lot to cover, so in the interest of time, we'll get straight on. Don't have any disclosures. I'll focus mainly on the clinical features of Parkinson's and management, where I'll be talking mainly on pharmacotherapy and device therapies, and maybe a glimpse of what may be on the future with some late-breaking trials from the movement disorder meeting in Hong Kong in October this year. A correct diagnosis of Parkinson's disease is absolutely essential for correct management, and everything flows from getting the diagnosis right. And even in this day and age, the diagnosis of Parkinson's is still primarily a clinical exercise. There is no test or scan or biomarker still available that will say that yes, this individual has or does not have Parkinson's disease. And there is nearly a 20% inaccuracy or diagnostic uncertainty at the initial presentation, and up to 30% of patients get reclassified in specialized units with the original diagnosis. We've known about Parkinson's disease for a long time. James Parkinson's seminal essay was back in 1817, and that description still fits today, and it was based on his astute observations of only 6 cases. That's a classic illustration of Parkinson's disease, which a lot of you will recognize with your own symptoms, and that was way back in 1886 in William Gower's Manual of the Disease of the Nervous System. A quick word on the epidemiology of PD. It's the second most common neurodegenerative disorder after Alzheimer's disease, and increased age is the biggest risk factor. With our growing and aging population, we're seeing a lot more of these neurodegenerative disorders, especially PD. The lifetime risk is 2% for men and 1.3% for women above the age of 40 years. In other words, the prevalence is 1% in people older than 60, 3% in individuals above the age of 80 years. So it's very, very common. Epidemiological data has shown some risk factors and maybe some potential protective factors for Parkinson's disease. Pesticides, increased dairy consumption, melanoma, and traumatic brain injury have all been associated with an increased risk for PD. Whereas smoking, not that we recommend anybody to smoke, has been shown to be protective, but coffee is good, I love my coffee, caffeine, physical activity, and maybe some potential medications like anti-inflammatories and calcium channel blockers. And that's just a graphic illustration of what I just said. So, when we talk about the clinical features of Parkinson's, we're actually describing a syndrome called Parkinsonism. And we have 6 cardinal clinical features: a resting tremor or a tremor at rest in a fully resting limb. The tremor is not present on movement. Bradykinesia, that term means slowness of movement and reduced amplitude of movement. Rigidity, or in very simple terms, stiffness in muscles or stiffness in your body. Loss of postural reflexes, which means imbalance and an increased tendency to fall. A stooped forward flexed posture, and freezing, where you suddenly have the inability to move. These are the 6 cardinal features of Parkinsonism. And a combination of these is required to make a diagnosis of Parkinson's disease. Definite Parkinsonism means that you have 2 of these features, and one of them is either a tremor at rest or slowness of movement, bradykinesia. Probable Parkinson's means resting tremor or bradykinesia alone, and possible Parkinson's is you have 2 of the remaining 4 features, but you don't have a resting tremor or you don't have slowness of movement. I just wanted to show a quick video that a lot of you might identify with.
Backwards from 20 to 1 by ones.
20, 19, 18, 17, 16, 15, 14, 13, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Wonderful.
As you can see, there was a resting tremor in the left hand. There is a re-emergent tremor when the hands are held outstretched.
Your nose, my finger, your nose.
There isn't really a tremor on movement, and that's one of the main distinguishing features of Parkinson's disease. Tremor is present at rest.
Your nose, my finger. Your nose, my finger. Okay.
And that's what's called slowness of movement, bradykinesia, and decrement, a small amplitude of
All
movement.
the way. Close and open.
And it's more prominent on the affected side.
Close, close.
Okay. There's another quick video just demonstrating the tremor in more detail. I want to show you some of my own cases that gives you an idea about the sort of spectrum of Parkinson's disease. As Steve just said, you put 10 Parkies in a room and everybody will be totally different. The first one is a young onset Parkinson's disease, 48-year-old gentleman who was diagnosed at the age of 41 in New Zealand. His initial symptom was only a left frozen shoulder, pain in his shoulder. I first met him in 2016 when he moved to Canberra. At that time, he was still working full-time, and his main problems were fatigue, low energy, poor sleep. And he was on a combination of Madapar 5 times a day and Sinemet 5 times a day. You'll all be familiar with these medications. Fast forward 2 years and he's no longer working. He can't handle the stress of a full-time job. He's self-employed. He's starting to have some freezing in the morning. He has dyskinesias, which are involuntary movements that happen in the later stage of Parkinson's disease. And his medication burden has gone up. He's now also on entacapone and some Cifrol. Mr. CD is a 60-year-old gentleman who was diagnosed in 2013 by me when he was 54. His initial symptom was no arm swing. He couldn't swing his arm when he walked, and that's a very common initial symptom of Parkinson's disease. Very fit and active gentleman, working, playing sport. His examination findings were very mild and subtle. He had very mild slowness of movement. He had some stiffness, and I just started him on a single agent Cifrol, which is a dopamine agonist. 2 years later, he has progressed. We had to start levodopa in 2017, which is the most potent drug that we have for Parkinson's disease. He now has some reduction in fine motor skills, and he now has signs on both sides, whereas initially everything was on his left, and obviously his medications have gone up. He's now on Sinemet, he's on Azilect, he's on Cifrol. I'm just using the common brand names. Mr. EF is a 63-year-old gentleman who was diagnosed by another neurologist, Dr. Hammond in Orange, when he was 48 years of age, a young onset Parkinson's. And he was referred to me by another neurologist for consideration of advanced therapy, which I'll talk about later. His initial symptoms were tremor and reduced arm swing. He had to give up work. He used to be an electricity meter reader, but he stopped working in 2011. And when I saw him, he was quite bad, couldn't walk, immobile in the evenings, a lot of freezing, despite on a lot of medication, 6 times a day of tablets and stuff. So I thought he was appropriate for Duodopa, which we did in June 2016. 2 years later, he's okay. He's enjoying his golf again. He can walk. There's no freezing. And he's only on the Duodopa pump and just one medication at night. Another patient of mine is a 66-year-old academic whom I first met last year. She was diagnosed in 2009 with an initial symptom of tremor in the right foot. Was put on levodopa by her neurologist, but progressed to have dyskinesia, severe nausea and vomiting, really couldn't take oral medications. And she had deep brain surgery done in one of the centers in May 2016. and was very good for 2 years, but then started to have some difficulty and some dragging in her right leg. So I thought that maybe she will need a bit of a titration of medication. She wasn't really on anything when I saw her, except that she had the deep brain stimulation surgery. And she's still doing well, traveling and teaching, and is still on DBS and very low dose of medication. So she's doing really well. So there's a lot that we can do in the advanced stages of Parkinson's, and I'll come to that. And finally, another patient of mine, an 82-year-old lady, was diagnosed back in 2012 by her geriatrician, progressed rapidly over 5 years, and when I saw her was quite advanced, was having falls, poor mobility. I offered her Duodopa, but she didn't really want to do it. It's a complex treatment. And now 2 years later, she's in a nursing home, very poor mobility, continued cognitive impairment, and not doing well despite on a lot of medication. So you can see that Parkinson's disease is complex, is very, every individual is different. There's a big spectrum to the disease. I want to touch very briefly on prodromal PD because, as Steve said, now we know that Parkinson's disease can start 20 years before people start to have symptoms, before we can even make the diagnosis. We think that Parkinson's disease starts in the gut, and if you can see that graph, it clearly shows that the pathology starts with deposition of abnormal protein in the gut, and that slowly then spreads to the brain, and by the time that happens, it can be 5, 10, 15, 20 years. Before the onset of the clinical symptoms of Parkinson's, people have other symptoms, which are loss of smell or reduction in smell. We call that hypoosmia. RBD stands for REM, sleep disturbance, and many of you may recognize this. You have violent dreams, vivid dreams at night, nightmares. You act out your dreams, cry, kick, punch, and that can happen 10, 15 years even before the hint of a tremor. Autonomic symptoms are problems with heart rate, drops in blood pressure, constipation, and mood problems can precede Parkinson's by many years. You can have depression and anxiety secondary to the deposition of protein in various of the abnormal alpha-synuclein protein in various areas of the brain. And that's just a nice diagram, shows how the abnormal protein migrates through various areas of the brain, and as different areas get involved, the clinical features start to come up. These are the premotor symptoms or the non-motor symptoms that precede the development of Parkinson's, and I've just talked about those. All right, coming to how we diagnose Parkinson's disease, it's still a clinical exercise. No blood test, no scan, no MRI, no genetic test that definitively gives us a diagnosis or definitely separates the different types of Parkinsonian disorders. We use certain clinical diagnostic criteria called the MDS clinical diagnostic criteria. MDS stands for Movement Disorder Society, which is the peak international body that researches and looks after movement disorders in general. That's just a list of the criteria I've talked about there earlier. You need to have either a resting tremor or rigidity to make a diagnosis of Parkinson's disease. You need to have absence of certain things, and I'll talk about those later, or in more simpler terms. These are just the sort of clinical MDS criteria. There's a lot of medical jargon there. How good are we in making a diagnosis of Parkinson's disease? Well, there is still a degree of inaccuracy. The diagnostic accuracy is only about 80%, and there are a number of studies that have been done, and there is this meta-analysis that I've put up which shows that even in the best of hands, even with movement disorder experts, so these are neurologists who just look after Parkinson's disease and nothing else, the diagnostic accuracy is only 79 to 82%. So there is still a lot of uncertainty when we first see someone with Parkinsonian symptoms. And why is that? There are some pitfalls, and there are a few mimicking syndromes or other conditions that can mimic Parkinson's disease, and I'll briefly talk about those. The two commonest ones that we get in clinical practice are, is this Parkinson's disease or is it essential tremor? And is this Parkinson's disease, or is it one of the Parkinson mimic syndromes? And there's a list of those names there: multisystem atrophy, progressive supranuclear palsy, dementia with Lewy bodies. Is it a secondary type of Parkinson's like drug-induced, or is it due to a stroke called vascular Parkinson's, or is it something like normal pressure hydrocephalus, which is dilatation of the fluid cavities of the brain? So there are a lot of diseases or conditions that can mimic the clinical features of Parkinson's, and it just makes our job harder. All right. Essential tremor is probably the commonest thing that we have to differentiate between Parkinson's disease because it's a tremor, and tremor is the presenting symptom of PD in 80% of people. Essential tremor usually presents much earlier than the classic presentation of Parkinson's disease, which is in the 50s and 60s. Essential tremor can be present for decades, so people start off in their 20s and 30s before they come to medical attention. Someone who has a tremor due to Parkinson's disease will usually seek attention within 12 months because other symptoms appear. About 30 to 50% cases of essential tremor are misdiagnosed. I've seen it many times when I've seen someone whom I thought was essential tremor, and 2 or 3 years later they present with other signs and symptoms of Parkinson's disease. In pure essential tremor, the individual should not have rigidity, which means stiffness. They should not have slowness of movement, bradykinesia. Essential tremor is affected by alcohol. If you have a couple of drinks, your tremor will go away. Nice to know. There is a positive family history. It is an autosomal dominant disease, which means it runs in each generation. It affects handwriting. It shouldn't really affect your posture or movement. There's another little video that tries to show the difference between an essential tremor, which is tremor on movement, as contrast. So you can clearly see that when she tries to touch the finger, tries to touch her nose, her finger is wobbling around, and that's a kinetic tremor or an action tremor. It's not a tremor at rest, and that's one of the main differentiating features between essential tremor and PD. Pitfall number 2, this is also quite difficult and challenging. Whenever someone presents with Parkinsonian clinical features, we always have to keep the Parkinson mimic conditions at the back of our mind. And I've listed the 3 common ones: multisystem atrophy, progressive supranuclear palsy, and corticobasal syndrome. And they all have their own typical clinical features that help us distinguish. But in the early stages, it can be very, very hard. They all look exactly the same as Parkinson's disease. There are some red flags that we consider when someone presents to us for the first time with Parkinsonian clinical features. And if any of these are present, then we think that the diagnosis may not be Parkinson's disease. So if there is early onset of dementia or cognitive impairment, if someone has symmetrical signs, which means that they have bradykinesia or slowness of movement or tremor bilaterally, both sides of the body are affected, then it's usually not Parkinson's disease. Parkinson's disease is asymmetrical. It will always start on one side in one limb and then slowly spread to the other, and that can take years to happen. If there is early problems with swallowing, that's what bulbar dysfunction means, swallowing or speaking. So early difficulty with slurred speech or abnormal speech or difficulty swallowing, then it's not PD. Early falls. So if you're falling within the first year of onset of symptoms and have difficulty walking, then it's not Parkinson's disease. It's probably something else. So these are the sort of common red flags that we look for when we evaluate someone and we want to make a diagnosis of Parkinson's disease. These red flags should not be present. PD will evolve. It will slowly progress over years. It's a neurodegenerative disorder, and unfortunately, so far, we don't have any disease-modifying treatment that will slow down the progression of the disease. And we try to sort of split it into an early stage, a middle stage, and a late stage. In the early stage, individuals have mild symptoms. They have a very good response to medications, very good quality of life. In the middle stage, you start to have fluctuations, and I'll talk about what fluctuations are a little later. These fluctuations will still respond to medications, which is dopamine. But in the late stage, people have a lot of problems, unfortunately. There are both motor symptoms and non-motor. When I say non-motor, non-physical symptoms that really don't respond to our current medications. Again, the middle stage can be sort of split theoretically into predictable and unpredictable stage, depending on the response to our treatments. So, how do we manage Parkinson's disease? And I'll be focusing mainly on pharmacotherapy, and then a bit about the advanced therapies that we have. And these are the topics that I'll try to cover. We need a whole team to look after individuals with Parkinson's disease. We need the carers, we need the physiotherapists, we need the Parkinson nurses. It's a multidisciplinary team because it's a very complex disorder with a whole range of physical and non-motor symptoms. Parkinson's disease would be an ideal candidate for neuroprotective therapy, something that will stop the disease from progressing, because we have a preclinical period, which I showed you, the prodromal phase, where the disease starts in the gut, and that can be as long as 20 years. Even after someone is diagnosed with Parkinson's disease, it progresses over 10 to 20 years, so it has got a slow progression rate. So even if we can do something to halt it, it would be great. And our understanding of the disease is increasing. We know a lot more about what happens now at the molecular level. However, so far, everything that we have tried, all the double-blinded clinical trials looking at various treatments for neuroprotection or to stop the disease progression, have been very, very disappointing, and they've all been negative. Those are some of the agents that have been looked at, and some are under active investigation, and Professor Cooper will obviously talk a lot more about those, or other things that are current at the moment, but so far nothing has worked. Nothing has been shown to slow down the progression of Parkinson's disease, and that's very disappointing. Okay, what do we have currently in our armamentarium to manage Parkinson's disease? I've just listed the common drugs, and you'll probably be familiar with a lot of them. We have anticholinergics. The brand names are Artane and Cogentin, which we use to try and control people who have severe tremor. Amantadine or Symetril, which is the only medication that has been shown to reduce dopamine-induced dyskinesias, which some of you or a lot of you may experience. Dyskinesias are involuntary movements where you just shake after you have taken levodopa. Levodopa is the most potent drug and the gold standard and the mainstay of therapy. It's basically a precursor of dopamine. It's in a tablet form. You take the medication, your body has an enzyme which breaks it down, converts it to dopamine. It crosses your blood-brain barrier and acts on the dopamine receptors, and that's how the symptoms of Parkinson's disease improve. We do have a lot of dopamine agonists which mimic the action of dopamine and directly act on the brain receptors. And 2 are available in Australia out of that list: pramipexole, which is Cifrol, and rotigotine, which is the skin patch, the Neopro patch. And then we have the COMT or catechol, that's a tongue-twisting word. Inhibitors, basically medications or enzymes that prevent dopamine from breaking down and prolonging the action of levodopa. There are a lot of medications under study. Some of them are neuroprotective agents to try and slow down the disease. Some are for symptomatic treatment of Parkinson's, and they're all under clinical trials at the moment with a lot of phase 2 studies that have happened so far. Okay, so as I said, levodopa, we know it as Sinemet, Kinson, or Matopar, is the most effective medication. So far, it's been around for years and decades. We haven't found anything better to treat Parkinson's disease, despite all our advances. As I said, this enzyme, dopa decarboxylase, breaks it down in your body, converts it into dopamine, the active substance, and then dopamine crosses the blood-brain barrier and acts on the dopamine receptors. Levodopa has a lot of side effects, which we probably all experienced. Common side effects when we start the medication are nausea and vomiting. Low blood pressure, orthostatic hypotension, that's what that means. So when you stand or when you change position, your blood pressure drops down to your boots, you feel dizzy and lightheaded. It will make you sleepy. It can cause confusion and hallucinations. That is usually seen at big doses. And the most troublesome side effect is dyskinesias, which is the involuntary movements that usually happen 7 to 10 years after someone has been on the medication. We also have dopamine agonists. So levodopa and dopamine agonists are usually our first-line potent medications that we start when someone has been diagnosed with Parkinson's disease. And these two are available in Australia, Cifrol and Neupro. Because they act directly, they cross the blood-brain barrier and act directly on receptors in the brain, we don't need things like metabolic conversion. The side effects are similar to levodopa, so nausea, vomiting, drops in blood pressure. Daytime sleepiness, people have micro attacks or micro sleeps when they're on these medications where you just nod off and have what's called a sleep attack. But the major concern with these medications are the behavioral problems or the neuropsychiatric side effects, where you can develop obsessive compulsive behavior, pathological gambling, hypersexuality, punding. These are the things that we are worried about and which we monitor and watch for whenever we put someone on these agents. Selegiline and rasagiline are very different medications. They block an enzyme, monoamine oxidase. And by blocking that enzyme, what it does, it basically allows dopamine or levodopa to be available for a long time. And it potentiates the action of dopamine. They are modestly efficacious drugs. They're not very potent. They have their own side effects, which some of you may have experienced. Abdominal pain is the most problematic one that I see in clinical practice. But they can cause dyskinesias, weight loss, headaches, low blood pressure, constipation, dryness of the mouth. Yes, modern medicine is not fun. Whatever we use, there are potential side effects. And the last one is Comtan or entacapone, which we usually start in the later stages of the disease when someone is starting to have fluctuations, because again, it prevents the degradation of levodopa, allows it to be available for a long time, and it prolongs its action. And it can have its own problems. The commonest one where we have to stop it is diarrhea and abdominal pain. People just don't tolerate it. Anticholinergics we use rarely because they cause confusions and hallucinations, especially above the age of 65, which is the predominant population for Parkinson's disease. And they mainly reduce tremor. They have no effect on any of the other symptoms of Parkinson's disease. So we use them, but very sparingly. They're not very commonly used. Which medication to start and when to start? Basically, all we can do at this stage with Parkinson's disease is control the symptoms and improve quality of life. We can't cure the disease, we can't stop disease progression, unfortunately, and therefore we start treatment whenever someone is noticing either functional, occupational, or social disability related to Parkinson's disease symptoms. About 70% of patients will need medications within 2 years of disease onset. In the initial stages or early stages, we can use less potent medications like rasagiline. But if you have disabling symptoms, the choice is either levodopa or a dopamine agonist like Cifrol or rotigotine. Which one to start? Does it make a difference? There was this very nice study that came in the Lancet in 2014, which looked at this question and divided patients into 3 groups, one on a dopamine agonist, one on levodopa, one on Azilec, and studied them long-term over 7 years and found that there was absolutely no difference in the outcomes in whichever medication was started. However, patients who were started on levodopa did notice that their quality of life and mobility was better compared to the other 2 groups. So, what I do in clinical practice, if it's a young patient, less than 50 years, we either start off with rasagiline because it's well tolerated, has symptomatic improvement, or a dopamine agonist, unless they have really disabling motor symptoms, because levodopa is still the best drug that we have. It should be used in any patient with Parkinson's disease regardless of the age. In older individuals, we go straight to levodopa because the other drugs do have significant neuropsychiatric side effects like the behavioral abnormalities. Parkinson's disease, as we know nowadays, has a lot of non-motor symptoms: low blood pressure, pain, constipation, cognitive problems, mood problems. And in the later stages of the disease, after 10 to 15 years, they actually predominate the clinical picture, and they're very, very hard to treat. We don't treat the non-motor symptoms very well. We can only do symptomatic treatment, and it's not very, very good. If you have swallowing difficulties, we get our speech pathologists involved. We do diet modification. Tube feeding does not improve quality of life. It prolongs life. So not many patients go for that, and none of my patients have ever opted for tube feeding. As I said, people can have a lot of cognitive problems. After 20 years of Parkinson's disease, dementia is inevitable. We call it Parkinson's-associated dementia. And again, there's not much that we can do for it, unfortunately. Rivastigmine, which is an Alzheimer's medication, is the only approved drug. Depression is very, very common. About 50% of patients with Parkinson's disease experience depression, and we treat it with standard antidepressants. And there are further talks this afternoon on how to manage the neuropsychiatric problems of Parkinson's disease. I want to focus a bit on advanced PD because there's not a lot of awareness about it, and we use this to manage the motor complications of Parkinson's disease. So after 7 to 10 years, a lot of patients will start to have a poor quality of life, and that is due to fluctuations. You start to go up and down. You don't have a predictable, smooth response to medications, and that's because you have a narrow therapeutic window. If you go below that level, you become off. If you go above, you have dyskinesias. So you can have on or off episodes, you can have drug failure, you can have dyskinesias. So we have 3 treatment options for advanced PD: apomorphine, Duodopa, and deep brain stimulation. Apomorphine looks like that. It's like an insulin pump. There's a subcutaneous needle, and you get a continuous infusion of this agent. It's a dopamine agonist. It also comes as intermittent rescue injections if you experience freezing, and it basically reduces dyskinesias. It reduces your off period when you don't have any medication effect, but it has a lot of complications, and the main one being basically intractable nausea and vomiting, which reduce the tolerance of it. There are some studies that have shown its effect. Levodopa, carbidopa intestinal gel is Duodopa. There are some patients that I have for which I've done this therapy. It's highly effective. It's a complex therapy where you require a procedure called a PEG tube, where a tube is inserted into your intestine through the stomach wall to directly deliver the medication there. There's a lot of evidence that it's highly effective. It results in significant improvement in quality of life and motor symptoms and a reduction in the off time and dyskinesias. But it's a complex treatment. There can be complications with the procedure. People can develop nerve damage in the feet called neuropathy due to lack of micronutrients and stuff. At the moment, I've got about 7 active patients on Duodopa, 1 in hospital right now, and patients have failed because they couldn't cope with the complexity of treatment when we had to withdraw. Deep brain stimulation you may be aware of. This is where we put electrodes in the brain to stimulate various areas, and you have something like a pacemaker put into your chest wall, like what the cardiologists do, and the implants and electrodes go into your brain. And it's quite effective in improving the physical or motor symptoms of Parkinson's disease, but it has complications. The major worry is that can cause cognitive impairment or accelerate dementia, and we tend to reserve DBS for individuals under the age of 65. None of these treatments, including DBS, cure PD or stop the progression of PD. They just help with the motor symptoms and improve quality of life. Which one to use? Duodopa, which is the pump that goes in through the stomach wall, or DBS are the most effective. Apomorphine, not so much. We are limited by logistics and lack of expertise in these complex treatments, and there are very few centers that do these. I'm going to skip through this. Cannabis, no evidence that it does anything. Nilotinib is controversial. It's a chemotherapy drug. I just want to show something that came out very recently from the Hong Kong conference. Non-invasive brain stimulation. So instead of putting electrodes on the brain, we can put magnets on the scalp, no need for surgery, and that has been shown to result in improvement of symptoms. A low-fat diet may show improvement, we don't know. Very small study with only 47 patients. Light therapy, there's a lot of noise about it, but this is the first time we've had a study with 94 patients that showed using light therapy with infrared light resulted in improvement in their symptoms. And the future, the goal, what we want is something that will cure Parkinson's, where we can have stem cells that will result in dopaminergic neurons that will halt the progression of the disease. So in summary, a very complex disease, lots of diagnostic challenges and still uncertainty. We still don't have a cure or a disease-modifying treatment, and management can be very, very challenging. Thank you very much.